So let's take a look at restrictive pulmonary disorders. So let's take a look at interstitial lung diseases. This is a group of more than 180 pulmonary disorders that if we don't take care of it, if we leave it untreated, that inflammatory process can progress to irreversible fibrosis. And fibrosis is thickening or scarring of the tissues. So if you look here on the right, on the left side is your normal alveoli, and on the right side is your abnormal alveoli. And when you look at the abnormal alveoli, you see that there's damage and thickened interstitium. So the oxygen is slow to move into the blood, and the carbon dioxide is very slow to move into the alveoli. So what you end up is impaired gas exchange. Fibrotic interstitial lung disease, like we said, it's a restrictive disease characterized by thickening of the alveolar interstitium. It's restrictive because fibrosis, like we said, is thickened and scarred, so it doesn't have very good lung compliance. How does this happen exactly? It's not very well understood. They think that it might be some kind of immune reaction that usually begins with some sort of injury to the alveolar epithelial or capillary endothelial cells. And the pathophysiologic changes that are seen in diffuse interstitial lung disease may include interstitial and alveolar wall thickening, which we said that, but then you also have these collagen bundles in the interstitium that contributes to the fibrotic characteristic of this disease. The lung tissues, what happens here is the lung tissues become infiltrated by lymphocytes, macrophages, and plasma cells, and that's what happens when your immune system responds to something. Then you have inflammation of your alveoli, and then what happens there? It leads to your alveolar capillaries being destroyed. So as in emphysema, there's your normal bronchiole, and then your emphysema has these large air pockets. Another thing to look at is the acute respiratory distress syndrome, and I think I mentioned in the last slide that COVID-19 it can end up, and actually we had a lot of patients die of ARDS from COVID. So, what is it exactly? It's characterized by damage to the alveolar capillary membrane. It's associated with a decline in the PaO2 that is refractory to oxygen therapy. What does refractory mean? It's just that you can flood these patients with so much oxygen, it doesn't do anything. So that is called refractory hypoxemia. It is associated with severe trauma, sepsis. That's actually where most patients get ARDS is from sepsis. They can also get it from gastric acid aspiration. Many patients who are on tube feed, if you don't take care of them properly, if you don't position them properly, they can aspirate. Fat embolite syndrome can also cause ARDS, and shock from any cause can lead to ARDS also. The mechanisms of lung injury is unknown, but what happens here is that because of that immune response, there's increased permeability of the pulmonary vasculature. So you start out with an initial injury that may be caused by direct or indirect damage, and this causes an increased alveolar capillary permeability. So the alveoli, that capillary bed, they start becoming leaky. It leads to interstitial and alveolar edema. In a previous lecture, we talked about interstitial and alveolar edema. Basically, you have all these fluids and all kinds of debris that's flooding the lung tissues and then the alveoli. So you end up with impaired gas exchange. That's why no matter how much oxygen you give these patients, they're not going to do anything with it because you're giving it to them, but when the interstitium and the alveoli are flooded with fluids, then they're not going to be able to participate in gas exchange. They have what they call intrapulmonary shunting also, where if you're looking at that one collapsed alveoli there, alveolus there, and because it's collapsed, it's not going to participate in gas exchange because you can have blood go through it and try to put air through it, but it's collapsed. It's not participating in gas exchange, and the blood can go through it, but again, it has no ability to pick up any oxygen from the blood cells. So blood is shunted. So, common findings in ARDS is severe hypoxemia caused by intrapulmonary shunting of blood, and there is a decrease in lung compliance because again, there's fibrosis happening in there, and there's a lot of fluid in there, so it's not as flexible, it's not as elastic. There is also a decrease in functional residual capacity. And then when you look at this in the on chest x-ray, they look like ground glass. And then also you'll find non-cardiogenic pulmonary edema, which we said that there's fluids that's flooding the lungs. So just to review, functional residual capacity is that amount of air that is left in your lungs when you take your normal tidal volume, your normal breath in your normal expiration without any effort. And so that functional residual capacity is your expiratory reserve volume, that extra breath that you can exhale all the way till you can't anymore, plus what's left in your lungs after you do that. So functional residual capacity. And so why is it decreased in ARDS? It's because the lungs are so stiff, they're non-compliant because of all this alveolar edema and exudate. And this leads to atelectasis and loss of lung volume because you lose air, you lose that volume. So then what happens again? Impaired gas exchange. There's also decreased lung compliance. This is severe in ARDS. It results from loss or inactivated surfactant. So now we're losing a surfactant now too. So our alveoli that are already collapsing are collapsing more because there's no surfactant to keep them open. Then you have all these fluid, that proteinaceous fluid that fills the lungs and of course impairs ventilation. There's also decreased partial pressure of oxygen, and this is a result of perfusion of large numbers of alveoli that are poorly ventilated. So you have these alveoli that you could be sending blood to it, but they're not ventilated very well. So if they're not ventilated, they're not bringing oxygen to that area. So even though you have blood, the enough blood to be circulating in those areas, then it's of course, there's no oxygen that you're going to pick up, right? Or it could have large numbers of, you might have good perfusion, but you're going to areas that are not ventilated at all. So poorly ventilated or areas of low ventilation perfusion ratio or not ventilated. Those are the areas of shunt. So let's see. So how do we diagnose ARDS? Well, the hallmark of ARDS is that when patients have, we know there's lung issues, they have some problems with their oxygenation, but no matter how much oxygen we give these patients, they're not getting any better. So the hallmark of ARDS is refractory hypoxemia. Other things that we can do is to do blood gas analysis, and we talked about acute respiratory failure. That's going to show on there. The chest radiograph, that ground glass appearance. Then we do other things like blood and urine cultures just to see if that infection has spread to the blood or to the urine. On pulmonary function tests also to see how bad the lungs are, and you might want to do a lung biopsy in case or if we are suspect some kind of pulmonary malignancy. How do we take care of it? It's really mostly supportive. They have to be on the ventilator with positive end expiratory pressure. In fact, they are put on PEEP that are much higher than patients without ARDS. There's also infant respiratory distress syndrome. We're not going to go through this very thoroughly because well, you're probably going to talk about it in your pediatric rotation, but the difference here is that in infant respiratory distress syndrome is because there is a lack of pulmonary surfactant, and of course this leads to increased alveolar surface tension, and that means that your alveoli are collapsing, and then you have decreased lung compliance. What you see are hemorrhagic pulmonary edema, patchy atelectasis, and that glass ground appearance on chest x-ray. It will also have hypoxemia that is refractory, just like in adult respiratory distress syndrome. Let's talk about two pleural space disorders, pneumothorax and a pleural effusion. The difference between the two is that in the pneumothorax, there's air that's compressing the lungs, so the lungs can't expand. In pleural effusion, the lungs are collapsed because there's fluid in the pleural space. So let's talk about the different types of pneumothoraces. So a primary pneumothorax is characterized by the accumulation of air in the pleural space. It is classified as spontaneous, occurring mainly in tall, thin men between ages 20 and 40 without any underlying disease factors. I've actually seen this 3 or 4 times in my career. My last one I remember was a 20-year-old kid who was playing basketball with his friends, and then all of a sudden he started having chest pain. He's never had anything like that happen to him before, and he came in and he had a pneumothorax. Cigarette smoking does increase the risk of spontaneous pneumothorax. In the US, there are approximately 20,000 new cases every year, and this is 6 times more common in men than in women. Secondary pneumothorax occurs as a complication of some kind of pre-existing pulmonary disease. Like somebody with TB, for instance, will just all of a sudden have a pneumothorax, or somebody with asthma or emphysema will just have this pneumothorax. But the secondary is a pneumothorax that happens as a complication of something else going on with them, some pre-existing pulmonary disease. There's a specific category of secondary pneumothorax associated with menstruation. It's called catamenial pneumothorax. They don't really know how this occurs, but a catamenial pneumothorax serves primarily in the right hemothorax and is usually associated with endometriosis. The tension pneumothorax, this one is traumatic in origin. It's usually from some sort of penetrating or non-penetrating injury. It is a medical emergency. This lung needs to be reinflated, or the patients could die from this. Other examples of traumatic pneumothorax have what they call iatrogenic causes, as in it happens in the hospital, and that could be from the placement of central lines, thoracentesis, when we're trying to drain the lungs, and then so in a thoracentesis, you drain fluids that's in the pleura, but then they accidentally puncture the lung instead, and then they cause a pneumothorax. When they are biopsying a lung mass, for instance, they could accidentally cause a pneumothorax. Putting patients on the vent also, if the settings are too high, and we can cause a pneumothorax in patients. Sorry about that. Okay. So as you can see here on the top picture there, this is a spontaneous pneumothorax. I mean, this could also be a tension pneumothorax. So you see this in the oranges, that's air in there and it's pushing up on the lung, so the lung can't expand. What happens with this is when this becomes a tension pneumothorax, is that air pushes not just on the lung as it compresses it, but it also pushes on the other vessel, on the other structures like the vessels and the heart, and it can compress it that way also. And what that does is that, of course, it compresses all these vessels up there, and it compresses your heart. So it lowers your cardiac output. Patients' blood pressure can drop, and yes, they can die from this. So really the treatment to this is just to puncture it, reinflate that lung, and put in a chest tube. So this is, like we said, is an accumulation of air in the pleural space. And we already said that primary is a spontaneous pneumothorax, and this is from a rupture of some sort of small subpleural blebs in the apices up at the top of the lung. Oops, what's going on? And secondary is complications from an underlying lung problem, and a tension pneumothorax is buildup of air under pressure in the pleural space. What are the clinical manifestations that you see with this? You'll see patients having tachycardia, so especially in tension pneumothorax, because it's pushing up on that lung and it can't inflate. So your lungs and then your heart saying, "Oh, we need more oxygen." So you start having faster heart rate to get more cardiac output. The other thing is that where that lung is deflated, you're not going to hear very much. If you hear breath sounds, it's not going to be very loud. So it's a decreased breath sounds. And sometimes, depending on how bad it is, you won't even hear any lung sounds at all on the side where there is the pneumothorax. You'll also have hyperresonance if you were tapping on the chest. Then they could also have sudden chest pain, like that kid I was telling you about in that spontaneous or primary pneumothorax. He was playing basketball, and all of a sudden he had this huge, just sudden chest pain on his, I don't remember if it was right or his left side, but he had sudden chest pain on one side of his chest, and definitely dyspnea. How do we diagnose pneumothorax? We do a chest x-ray usually. You can tell on a chest x-ray immediately. And how do we do this? Depends on depends on the size of the pneumothorax. Because if it's not that bad, then hopefully the body will just absorb it. But if it is more than 15 to 25%, we'll put in a chest tube. I think this picture kind of gives you a picture of a tension pneumothorax here, where the air builds up in the pleural cavity, and because there's a hole there, and it could be from some kind of trauma. It could be some patient got stabbed or got hit in the chest, and that pneumothorax happens. We talked about iatrogenic causes also, and all the symptoms and how we deal with it. So pleural effusion, this is not a disease. It's a collection of fluid or pus in the pleural cavity because of another disease process. And as you can see here, there's a collection of fluid here. It could be pus also, and it compresses the lung. So we have this patient. She was 69 years old, Korean lady who came into the hospital because she couldn't breathe. She didn't really want to come to the hospital, but her husband made her. But I mean, she was really short of breath when she came in. And she came into they called me. I was actually working up in PACU, and they asked if I would go down to the ER and help because they need to put just a chest tube in this lady. So she had her saturation was 77. I don't even know. She was walking around, and she was kind of bluish around the lips. So she said, her husband said, yeah, she's been like that for a while, but she just wouldn't come into the hospital. But she really was so short of breath today. She was working in the garden. So the surgeon came down. Oops. The surgeon came down, and we put two chest tubes in her, one in the other lung and one in the other lung. And we had taken, just imagine this. So we had taken 1,500 cc's, 15, that's 1.5 liters. Imagine that in a bottle of Coke, right? Those bottles of Coke, the huge ones, are 2 liters. And we had taken 1.5 liters of pus out of one lung, and the other one was another 1,000 liters of pus. Can you imagine that? So I'm sure she felt a lot better, because after that, she said she felt so much better she wanted to go home. But no, she had to be admitted to ICU because she had pus in her lungs. She needed to get antibiotics, and I don't know how she didn't die from that, plus, or a blood infection. How does this happen? Well, with pleural effusion, there's some kind of changes that happens with those effusions, and the imbalance in these changes is associated with those fluid formation exceeding fluid removal. What does that mean? the fluid accumulates in the lungs faster than we can absorb it. So when there's pus in there, of course, it's hard to, you're going to have to treat that infection. But if it's just fluids in there, somehow it's building up in the pleural space, and it's building up so fast that the body doesn't have the chance to absorb it. What do we see? Well, I mean, if you think about it, like I said, if you think about the pathophysiology of how things happen, you have fluid or pus in the lungs, it's compressing the lungs. So what do you think you're going to be seeing? You're going to be seeing shortness of breath. You're going to see dyspnea. You're going to have some sharp pain in there, sharp pleuritic pain, meaning that when you take a deep breath, it hurts. Because heart attack, it doesn't matter whether you take a deep breath or not, it's still going to hurt. Well, in a pleural chest pain, when you take a deep breath, it's worse. She might also have a dry cough. She is probably going to have decreased chest wall movement. I need some water. She probably is going to have decreased chest wall movement because she's trying not to breathe because it probably hurts. And she probably can't take a very deep breath anyway because it's squishing her lungs. So again, she might have that dullness because it's fluid in there. It's hyperresonance if it's air, and if it's dullness if it's fluids. And so there's going to be a massive pleural effusion can lead to a movement of the trachea, just like in a tension pneumothorax. When there's so much air in there, what it does is it starts pushing on the trachea, it starts pushing on the heart, it starts squishing the heart. But it usually a pneumothorax, a tension pneumothorax, happens a lot faster. So it's definitely an emergency. We need to do something right away because it can also get so much bigger. A pleural effusion is still an emergency if it starts squishing the heart, but usually it's not a quick thing that happens. You don't just all of a sudden have except in rare occasions maybe, but you don't have a all of a sudden accumulation of fluid that you need to drain it immediately. So, okay, how do we diagnose it? We usually go in a thoracentesis where you drain the fluid or pus out. That's what we did with that Korean lady, and wow, she wanted to go home immediately because I'm sure she felt so much better, but no, it took a while to convince her to stay. A chest X-ray also helps to look at that, look at to diagnose the pleural effusion. And if they want to, they can go in and send over a CAT scan. They can do it also ultrasonography also. And what do? We just basically we relieve those symptoms then by doing a thoracentesis. There are neuromuscular disorders that you should know. Polio is a viral disease where that poliovirus attacks motor nerve cells of spinal cord and brainstem. And why does this matter in a respiratory disorder lecture? It's because this affects the diaphragm and intercostal muscles, resulting in weakness and paralysis, and can lead to respiratory failure. At least 95% of infections are asymptomatic. You don't even know that you have it, and then all of a sudden it's there. Patients with minor symptoms present with fever, headache, vomiting, diarrhea, constipation, some sore throat. But respiratory function will generally recover, although some patients will have chronic respiratory insufficiency if they've had this in the past. Amyotrophic lateral sclerosis, also called Lou Gehrig's disease, is a degenerative disease of the nervous system. It involves both upper and lower motor neurons. Again, why does this matter? Because it is a clinically progressing muscle weakness and wasting that will at some point involve the respiratory system. So eventually leading to weakness of the respiratory muscles and can lead to death and does lead to death. So how fast the course of this disease is kind of individual for each patient, but usually they kind of just keep deteriorating, and it's irreversible. Okay. Don't worry about the muscular dystrophies. But know about Guillain-Barré syndrome. This is also called acute polyneuritis. It Polyneuritis. Polyneuritis. It's a disorder that is presumed to have an immunologic basis, and it is usually from some kind of infection from a Campylobacter jejuni, it's called. Um, but it's characterized by demyelination of the peripheral nerves. And how does this affect the respiratory system? Clinically, weakness and paralysis begins symmetrically from the lower extremities, and then it starts to progress upwards. So, Guillain-Barré syndrome starts from the upper extremities, and it starts from the lower extremities and starts to progress up all the way up to your upper, and then all the way up to your upper extremities, and it affects the trunk. So, in severe cases, the respiratory muscles become very weak, and of course, if the respiratory muscles are very weak, then you have problems with breathing. Myasthenia gravis, experience weakness and fatigue of the voluntary muscles. And this one, the hallmark of this disorder is weakness made worse by exercise and improved by rest. So when the patient is doing something, all of a sudden they feel very weak, the muscles are weak, but then it gets better when they're resting. So that's the hallmark of this disorder. um, Females are more affected than males. The primary abnormality is found at the neuromuscular junction, and it's a chronic illness. The manifestation that is seen can be managed by medications. They do have to take these medications exactly, whatever time it is that is prescribed. Respiratory failure here can result from the increasing severity of the illness, or if the patient is over medicated. Let's take a look at some chest wall deformities. So there's kyphoscoliosis, as you can see there. It could be idiopathic or maybe related to, or the patient may have been born with it, or some kind of neuromuscular disease. As you can see, it's that misshapen spine. And of course, if you have a misshapen spine, everything else in your trunk, like your lungs and your heart, are affected by it because of the way that is the way the spine is curved like that. Other things is called, another chest wall deformity to look for is the ankylosing spondylitis. You can see that the patient normally, when you're sitting up, the one on the left, you have that normal S curve, and in the patient with ankylosing spondylitis, they kind of have that this sort of stooping kind of posture. Another one, and this is trauma related here. This is really interesting to watch. This is a flail chest. What's happened here is you have multiple rib fractures that are just kind of floating. So think about what your ribs look like, and they're attached to your chest wall, but there are these floating ones, right? So when you have rib fractures and they're not attached to anything, then you end up with a flail chest, where when the patient takes a deep breath, instead of your chest going up because it's inflated, that little piece gets sucked in. So let's take a look at that video. It's pretty dramatic. So he's gonna take a deep breath, take a deep breath, take a deep breath. See how it's going paradoxically. So that takes significant force to do that. Okay, I think you get the idea. Okay. We also have disorders of obesity. And of course, we all know what obesity is. I don't need to explain that what that is to you. But there are some things that cause obesity, and one of those it could be from endocrine causes. Hypothyroidism also can cause obesity. And why is this important? Because when patients are so obese, they have so when a patient is obese, you see fat on the outside, but there's also fat on the inside. And what it does is it's squishing all of your organs inside, including your lungs. So when you have all that fat that's squishing your lungs are not able to inflate as they should. So you lose that ability to inhale very deeply and fill up your lungs as much as you can, because you lose that ability to inflate it well, because there's all this fat in the way. So what happens? Patients, obese patients generally don't they don't ventilate very well because it's hard for them to take a deep breath, and so they end up with these shallow breaths, kind of. And so you have decreased alveolar ventilation. They get kind of sleepy, because somnolence, they get sleepy because they're not getting enough oxygen to their brains. They could have severe hypoxemia. These patients can have they'll have to be on BiPAP or CPAP at night because they have sleep apnea where they stop breathing at night. And that's not good, because then they keep decreasing their oxygen intake at night when they do that, because they stop breathing. Polycythemia also, they could have a ton of these blood disorders. And then right-sided heart failure. Pneumonia is an inflammatory reaction in the alveoli and interstitium of the lung. It's usually caused by some kind of infectious agent. So it can result from three different sources when patients aspirate. That happens a lot, especially in older people. And when we inhale things like a virus, or it could be contamination from the systemic circulation, because something's going on, and then somehow it ends up in the bloodstream, and then it goes to your lungs, and then you get pneumonia from it. We also have community acquired or hospital acquired pneumonia, and it could be from bacteria and it could be from virus as well. Community acquired pneumonia usually occurs when your defense mechanisms are compromised, because you're walking around, all kinds of germs are in the community, and you don't normally, you just process it and your immune system takes care of it and you don't have any problems. But then when you have your immune system is compromised, and you encounter something that normally if you were healthy you wouldn't even have any problems with it, but you encounter a virus or a bacteria, and then you end up inhaling that, then it causes pneumonia. Old people tend to get pneumonia a lot because they're already immunocompromised, because they're older, and their lungs aren't as good anymore, and so they inhale something from the environment and they end up getting pneumonia. Viral pneumonia does not produce those the exudative fluids, like lots of mucus, like you would get in a bacterial pneumonia. So in bacterial, the things that you see are, you patients could have crackles, they have these loud breath sounds, bronchial breath sounds, then they could have chills and cough, and a very purulent sputum. So they have that green sputum that you see, and of course an abnormal chest X-ray. In viral pneumonia, you will have some wheezing and or some rails or crackles, they say, but you don't have that greenish thick sputum. How is gut pneumonia diagnosed? We take a chest X-ray. That's really how you diagnose it, and then we take some. What we do is we do some gram staining to see what kind of bacteria it is. That way, we can direct the kind of antibiotics to give them. So how do we treat it? Then you give them the antibiotic. That's why we do blood sputum cultures and blood cultures. That way we can take a look at what organisms are there and what kind of antibiotic are they sensitive to. And they usually will repeat a chest x-ray 6 to 8 weeks after the infection has been treated to see if it's gotten any better. Other inflammatory lung disease, severe acute respiratory syndrome, SARS-CoV-2 that was first reported in 2003. But so SARS, which was reported in 2003, and then the Middle East respiratory syndrome came around, and this is also that is very similar to the COVID virus. And then of course there's SARS-CoV-2, where there are three stages of increasing severity. You have the initial stage where you get that flu-like symptoms, including fevers, body aches, cough, and the dyspnea, and then you get into the second stage because now you've got inflammation of your lung tissue, and there's coagulopathy, and so it kind of increases your risk of developing blood clots. And then it develops into ARDS, and at the last stage, we talk about the lungs becoming fibrotic from ARDS. Now the lung tissues are thickened and damaged and scarred, and so you have problems with gas exchange. TB is caused by inhalation or ingestion of a bacteria, Mycobacterium tuberculosis. It's kind of a problem. I think Hawaii has the highest rate of TB in the country. That's why you have to have a TB shot. It seems like everywhere you go for any new place that you're going to work, they're going to want a TB test. And what happens here is that Mycobacterium tuberculosis, it spreads through the lymph and the blood. And that bacteria is ingested by macrophages and then walled off. So you end up with this bacteria inside this granuloma. So that's why it can stay dormant for many, many years because of that walled off areas of inflammatory cells. And that is the hallmark of tuberculosis, that bacteria that's enclosed in that wall. They're called tubercles, and that is the hallmark of tuberculosis. The things that we watch here, I mean, I don't know if you remember they would ask, have you had a fever? Have you have a cough? Have you had night sweats, fatigue, weight loss? Have you been coughing blood? Also, and the things and how do we diagnose it is that you do a PPD, and if it's positive, then you actually most places ask just for a quantiferin test now, because if you've had the BCG vaccine, which is usually in third world countries, if you had a BCG vaccine, you'll probably test positive for PPD. So they have now the quantiferin test. It's a blood test. And then they also will check for if they suspect that you have TB. Of course, they do a chest x ray, but they'll also do sputum cultures to take a look at that. You're usually put on antimicrobial agents if you test positive for TB. And this thing continues for 6 to 9 months, and a lot of people don't want to do this. There was a guy in Kau on Big Island. He had TB and he would just refuse to take his meds. So they had to send a nurse to go in and give him his meds because there's no way, they don't want him to be spreading TB all over the place. So, okay, that's it for our pulmonary.